Okay. Back on the commission, again, in the late 1970s, the legislature set up the Commission on Prepaid Health Plans. You know what I'm saying? And the commission spent 2 years studying the feasibility of introducing prepaid plans in North Carolina. And they did it regionally. They looked at the feasibility of IPAs, or Independent Practice Association, HMOs, for all areas of the state. And there's a fairly thick volume on those feasibility studies. And the conclusion was, yes, they were feasible in all the HSA areas of the state. They also commissioned Kaiser Permanente Advisory Services to do a feasibility study in the Triangle area on establishing a prepaid group practice. And Kaiser concluded that it was feasible if certain things took place, and primarily they were concerned about the laws, the HMO enabling legislation, and the support of physicians for that type of approach. The law part was taken care of through the commission, and Glenn Wilson amended the HMO, through the legislature amended the HMO Act in the early 80s. And it is now one of the best HMO acts in the country. Well, out of the commission came the recommendation, which was made back to the legislature and also to the governor, that to get prepaid plans going in North Carolina, they needed some organization to help to build the climate and to work with interested groups to develop HMOs in the state. And they recommended that the governor set up a nonprofit organization outside of state government that would take on this responsibility. And they also recommended a loan fund be set up, a $9 million loan fund be set up to loan money to HMOs wanting to develop in the state. The loan fund never was approved. This was back in 82. Actually 81. There were tight times, and I don't think even if they weren't tight times, it would have been difficult to get through the legislature. But the organization was, and that's what we came into existence in April of 82. Jim Bernstein is the president of the organization, and there is a board of directors made up of employers and providers. We have an 11-member board from across the state, and we've set out as our primary mission was to stimulate the development of prepaid plans in North Carolina. And our approach is to do it in local communities. We're not trying to get statewide HMOs. We're trying to work in specific medical communities to generate HMO development. That's our primary goal. And within that goal, we're also focusing on prepaid group practices. We think prepaid group practice is a critical piece in any HMO development activity in this state. And a second goal that we have is to work with local coalitions and to develop sort of community responses to the cost problem, and to assist these organizations in developing and operating. And we've worked with several. Our biggest efforts in Charlotte right now. We staff a large community-based coalition, and they're, and this is sort of a sideline, but their major project is a pre-admission certification program, which is being developed right now, and will be operational in April. But that approach is, now HMOs may become a part of it, but that's not the major focus of it. It's to get the people in a community together to put together a program that will work for that community. And we're very much geared toward a local approach to cost containment. And then we also have, and this has been one of my primary responsibilities, is to work with the Division of Medical Assistance. I know as Barbara Tula was on one of your agendas, but to work with her division in setting up prepaid plan options for Medicaid recipients. And right now, I've been working in Wilson County, in eastern North Carolina, with the provider groups down there to work on a prepaid arrangement. And Medicaid now has a federal waiver to implement such a program. And we might talk about that a little later. And data is another fourth piece, is data. And there's not, in this state, you probably know, there's not very good data on cost. There's pretty good data on utilization, but not on cost. And this is a big void, and right now we've been struggling, on what role the foundation can play in this. And we don't want to get into a data gathering role, but we want to participate in getting that data together. So back on our primary goal of competition and HMO development, and this gets back to, I think, the McClure paper, which from the pieces that you got, I think is the most important paper. And I like to spend a fair bit of time on it. And let me just say a few words as introduction to, and then maybe we get a little discussion going on. Our foundation is pretty much set up on those principles. We're trying to get, as I mentioned, trying to get local competition going. Ideally we'd like to see a number of different healthcare plans in each medical community. And these plans would compete against each other, and by doing so, we hope we'll control healthcare cost inflation. But recognizing that there are other approaches, and we're not totally locked into that model. Let me just say a couple words about the. I don't know if you had much on just healthcare costs. Is that something? I don't want to on the problem, and you've got a pretty good dose of that. Okay. Well, I don't want to cite any statistics or anything like that, but the problem in our present system, and the market forces needed to keep costs controlled just aren't working. The incentives of the system are geared toward generating more costs and more costly services. And part of what McClure is basically addressing those concerns. There are other approaches which he doesn't really touch on in that paper, but there is a regulatory approach which is gaining a fair bit of favor right now. And DRGs is in one way part of that approach. And there's another piece, the major risk insurance approach of Martin Feldstein, which says that calls for having the consumer pay a greater share of his health care bill. And the example that's usually used is But the consumer would be responsible for the first 10% for health care bill up to 10% of his income. So for someone making $25,000, they'd be responsible for the first $2,500 of their medical care costs. And the theory there is that if a consumer that has to pay his medical care will be a prudent consumer, a prudent buyer. And whether that works or not, I'm not sure. But I'd like to, we can get into a discussion on that. But McClure has combined sort of the prudent buyer theory with the competition theory, and into a into a type of plan that's widely in certain circles is widely felt to be the best type of approach to cost containment. Let me get some of your reactions to the plan. What do you see as its strengths?
I have a problem about weakness, or just I'm going to be working in rural Maine for an organization trying to set up some PPOs, and from this and from other material I've read, it sounds like they'll work in an urban area where you've got competition. We're talking about really dispersed area. You don't have the concentration of medical providers. And have you had that experience? How do you set up something like that in that situation?
Very difficult. I think that's a major flaw in the design. Because ideally, you're going to get, by the model, you're going to have, in a medical, say Raleigh, you'll have an IPA, you'll have a prepaid group practice, you'll have a PPO, you have a primary care network, all set up to offer their services to consumers, and they'd be competing on the basis of premium. But I do think it does, it requires a pretty good sized market. You can get a little of it, but you can't get, there's more a risk of getting a monopoly in a small community. And we're struggling with that as a company. My orientation's rural. I spent 10 years in rural health. And
what kind of approaches have you tried?
Well, I'll be honest. For the last 2 years, we veered toward the urban areas because we feel we've got to set the stage, and those are the logical areas. And my Wilson County experience is trying to get to introduce some competition in a rural area, but I'm not sure it's going to work. Because under that plan, what we're going to try to do is to capitate the physicians in two fairly large multi-specialty group practices in Wilson County, and they're going to be capitated at $12.50 per enrollee per month to provide services, all physician, all X-ray, all lab, and all family plan EPDSDT as well. We'll have to supply those or arrange for the provision of those services for enrolled population, and plus they'll share in the savings of any reduction in hospital. But
that's already a certain size.
Yeah, right. I mean, the only thing there, it'll turn the incentives around. I mean, this is an area where hospital utilization's been very high, and I think there's generally regarded that the groups tend to, over-treat and over-hospitalize.
Do you find capitation can be an incentive in the absence of competition?
Up to a certain point. I mean, I think it turns the incentives around, but without another force, being ready to pick up the ball, and to compete against the groups, I don't see it over the long haul being very effective. Because I think once you get the
how about
how to play the
your
game.
Involvement in the community? Is that sometimes a way of getting community groups to put the pressure on?
That can, but I mean the problem is, it's the same under fee-for-service. They have limited knowledge, and dealing with coalitions and physicians and the providers always have the upper hand. I mean, they have the knowledge, and for the layperson, it's very difficult to even discuss them.
The only agreement is designated service and walking feature. And there is also no capitation or prepayment of any other alternative design services. And I was confused on that. I thought that was sort of the whole point of all of these things, was not only to say this is what we'll say for this procedure, but also the prepayment. Is that just this particular person's description, or is that different?
No, that's the difference with PPOs. And, I'm not sure what, PPO is a lot of different things. I don't think there's any great definition yet, but one of the things is they definitely don't involve prepayment, and at least not to date. But all the sort of alternative plans don't necessarily involve prepayment. A prepaid plan is an HMO, but there's a larger group called competitive medical plans that do involve PPOs and healthcare alliances. And, I think the best way to understand it is that the new forms call for organizing providers into groups who then compete on the basis of premium, right? What the premium charge would be, or on service price for enrollees. So a PPO competes on the basis of price, not on premium. There's no premium involved.
Well, often it's a three-corner thing, though, because often you have tied in with an insurance thing with the employer, at which point it's the insurance premium that the employer is paying.
Right.
So you get two different ones going on.
Yeah, it's a funny bird, and they're. Lucy, you were.
The woman from Haynes came down.
Oh, did
because
she?
I'm taking Debbie Freund's course on alternative delivery systems.
Told you about the Haynes Plan?
Their plan.
Can you share with us? I think that's an interesting plan.
Maybe, why don't you present it if you're familiar with it, because I don't have my notes on that.
Okay. Well, the Haynes Plan, the Haynes Corporation in Winston-Salem was about, I think there are around 10,000 employees in Winston. And Jan Rivenbark is the Director of Benefits for Haynes. In Winston is Jan Rivenbark, yeah. Why, do you? You say it's probably about my age. About Jan's age. Late 30s. Well, how do you know Jan Rivenbark? I want to hear more. This sounds much more interesting than PPOs.
Open mouth.
But Haynes Corporation got just really upset about healthcare costs. And, in fact, I went to a session. I was invited to one last year at the Winston-Salem Forsyth County Medical Society, where Jan Rivenbark made a presentation, and it was to all the medical physicians in Winston-Salem, and he really laid it on the line. And he used a slide presentation of these comic book characters and sort of traced the experience of one of his patients through the medical care system in Winston-Salem, and came down at the end. He said, "Now you physicians, I'm going to give you a choice. Help me get out of my mess. You can either buy, I forget how many, 50,000 legs stockings, pairs of leg stockings, or you can get a handle on cost." Well, he didn't wait too long. He implemented his own program, and what they're doing is contracting. They opened it up pretty much to the general community, and they're contracting with physicians in Winston-Salem and also in Davie County on as preferred providers. And the providers, in signing up, will agree not to charge more than the median charge in the community. That's one thing. And they will agree to provide, to undergo utilization review, and that's really their major goal. And for that, they'll be directed patients, and the way Haynes will direct patients is by providing an incentive. They'll under their general plan, there's a $150 deductible, and the patient pays, I think it's 85% of charges. After that, up to $1,000 cap. And under the PPO, a patient that goes to one of the preferred providers is maximum payment is $10. So the charges may be $40, and if it's a PPO physician, the patient only pays $10, and up to the $150 deductible.
So is the physician out for the
No, he bills Haynes for that. He bills the actual charges to Haynes and gets the remainder. And
he's agreed that he's only going to charge $40 for this
yeah,
deal.
right. And it's a little early to say how well it's working. It just started about 6 months ago, but they do have over 100 physicians enrolled, and I don't know what did she.
She said their problem actually is once the bandwagon started rolling is limiting physicians.
Yeah.
They have too many physicians enrolling, and
Right.
then they'll lose their competitive effect.
Did she say how many patients are using it?
I'm sure she did.
The patient, and if a patient goes to a non-preferred provider, and the charge is $40, they pay, and they haven't met their deductible, they pay the full $40. So there is some incentive to use them,
And they're using just primary care physicians.
Right,
They originally had included OB-GYN, and I think they're cutting that out.
Right.
Just in the province of
in response to that, the doctors in Winston-Salem formed their own preferred provider organization, which is they're now marketing, and there's apparently 170 docs involved in that. So there is a little bit of competition going on. But I'm not sure how successful it'll be. Which in the background, you have the Winston-Salem healthcare plan, Reynolds plan, which is not really any threat to anyone there because it's only for Reynolds employees, so it doesn't really encourage much competition. Back to the McClure article. What do you think about his approach to cost containing? Do you think it's going to work, or is it just?
When you were talking about the public financing for low-income folks, last week when we were reading about different financing and all that, I had read about home care. And one of the ways they were doing this is a better way where, when first home communities they set up some home care programs, and a lot of times I was concerned about limits being set and what lump sum fee would be given to the agency by the government, say for Medicare and it goes to fund. And the concern about planning for inflation or this escalation of costs by that mechanism, because I can see that as being kind of like something type of down. Whether it's an HMO type of prepaid deal, or not. I don't have much of a background in that, area to speak to it, but I was wondering, are people doing the evaluation of how that's going to be controlled?
Trying to. Right. And the experience on on competitive models is fairly, it's fairly limited and fairly recent. So that you have certain areas of the country where there's a fair bit of activity, but it's pretty much been in the last five years. I have not seen any good evidence that, like say Minneapolis, where there's 7 prepaid or and other alternative plans, and they make it's almost 30% of the market. And for a while in the late 70s there was some indication that the rate of increase in healthcare costs was rising at a lower rate than the national average, or the average for cities of similar size. But I think in the last few years that been rising about as fast as everywhere else. So
he mentions and then says it's not going to happen what other people say actually is happening, which is that your alternate delivery systems simply raise their prices till they're just a hair whisk under your service. And he sort of says that's a straw tiger, but what I've seen says so. It is. That does happen.
I think it does too. I think McClure, and that was again written several years ago, and he addresses that issue now. And he says yes, it does happen, and the only way you can see to deal with it is short of the entry of new competitors, which is not that easy in a medical arena. It's up to the employer to to sort of act as one to lower his premium and keep the sort of the employee beating on the door to keep costs low. But I'll be honest, I'm a little bit cynical about this increased call for more cost sharing and higher deductibles. And it's happening. I mean, it's going. I mean, there are a lot of employers now that, particularly in this state, have been really changing their benefits packages and instituting greater cost sharing and a higher deductible. And that's McClure calls for it. And I've been in. He talked at a group in Charlotte. We had 200 of the largest employers in Charlotte at a meeting with the governor and McClure. And McClure, he goes down. He makes a great speech and everything. But people take away from that speech is cost sharing, and that's easy. Yeah, sure, we'll raise our deductible, and it's easy to understand. His other theories are pretty. You have to be around a while to understand or really think about it. So I've seen a lot of that, and my problem with cost sharing is that. The theory behind it is the consumer has to pay more. He's going to be more careful and more prudent in how he buys medical services. And I think the flaw in that is that when you're in need.
At what point do you kind of go through that limit? You can be prudent, but say for myself, if I'm a single person working, a job where you work for $22,000 a year, and I have to pay first $2,500. That's a lot, in my pocket. So what would that mean in terms of me, say, seeking some care at the point where I need to be hospitalized versus preventive care? Keep me out of the hospital.
Yeah, I think there's another flaw in that, in that solution. Is the physician. The medical account. It's a complex. The patient only has very limited knowledge, and most of the demand is really physician initiated, provider initiated. Very little of it takes. Very little. A consumer doesn't really have that much say about it, and so I think if you really want to tackle cost payment, it's got to provide incentives for the provider to be cost conscious, more than trying to create prudent buyers. Unless in the competition model where you're prudent in selecting a premium, choosing that insurance plan. And at that time, when you're feeling okay, you can make a rational decision in a way. You had that book on that checkbook, the federal government's.
Mm-hmm.
Yeah.
Well, and also,
Has everyone seen that book?
No, I brought it in for this class.
Look around, because that's sort of the competition model in reality. That's the federal government has laid out for all their employees all the different options that they can choose from, and they provide a certain amount to yeah.
Well, to what extent when a corporation is buying insurance, does it act sort of like a monopsonist, and so that it can be the buyer, and whereas your individual consumer is not very good at doing that? Do they find that when a corporation is negotiating the insurance rates for its employees, that you do have more market can happen by so they pretty much take what, even now that's still going on?
Well, I mean, they don't have many options, and they can look around for another carrier.
Mm-hmm.
I mean, a lot of them are going to, self-insurance, which.
But when it comes to the actual deliverers, you don't have much of that.
I mean, other than do what Reynolds did and set up your own plans. I mean, that's the only. That worked pretty well.
Yeah. But the threat of that isn't generally enough.
Well, you have to be fairly big. I mean, if you get together with a group you might, but then you may get in trouble with, antitrust.
Yeah.
But I think the federal approach, by giving employees the option each year, give them an option of types of plans to join, and give them some information on them, and let them make a decision. And also, I mean, that's. The multiple choice is a critical element of competition, but there's another one, and that is the employer has to provide a fixed contribution. And Floor touched on this, that if you merely pay whatever the plan calls for, then there's absolutely no incentive for the employee to choose a lower plan. But if you say, all right. In California, I think they take the median, but if the median between all plans is $150, so you say, okay, we're going to provide for each employee $150 per month for your insurance, and you pick. You tell us which plan you want, and if it's a Blue Cross, Blue Shield, high option plan or whatever, then you may have to pay another $30 a month. If you go with a lower option or an IPA or something, you may wind up saving money or getting more in benefits. Is it still going?
Yes, still going.
Can you clarify, so I thought I had it down and I was listening to the IPAs, are the independent providers association? Now, are they prepaid?
Yeah, they're prepaid in the sense that their premiums are prepaid. So the employee would pay, contribute so much a month. But then in a lot of IPAs, their providers aren't prepaid. They're reimbursed on fee for service.
Who reimburses?
The HMO, the prepaid plan. Let me just give you an IPA. There's two types of models. There's a single organization model in which the IPA and the HMO are one and the same. Now, the HMO is the organization that markets, administers, and sort of responsible for the the day-to-day operation of the plan. And then the IPA is the Association of Physicians who come together to provide services. And in a single organization, they're together. Physicians are the HMO and are the IPA. And they hire people to do the marketing and administration. And they cannot be federally qualified, no. And the other model is a dual organization where you have a separate organization, which could be a non-profit or for-profit, that is set up, that is the health plan, which people subscribe to. And this organization, in turn, contracts with an independent group of physicians to provide services. And typically if it's sort of a medical society initiated plan, the physician is paid fee for service usually with a holdback, 15% or 20% of fees. And this may be given back to the physician at the end of the year, depending on plan performance. If things go well, they'll get it back. If they don't, they'll be withheld to make up any deficit.
So in a sense, you're making work for agency.
Yeah.
Isn't Haynes looking to hold back? It seems to me that Haynes is looking to hold back too.
Are they?
I think so. I'm not sure.
I remember
We had a
that,
couple
yeah.
of speakers in there.
I didn't remember that. Maybe they are. So that's one model, and generally that type is set up by a medical society or medical society leadership. And for that model to be successful, it generally requires fairly heavy utilization review, because the incentives aren't very strong in it to contain costs.
So who is that organization?
The plan, the health plan, the HMO will set up a utilization review section, and they will screen all admissions, and they will also do concurrent review and retrospective review. I've seen the Physicians Health Plan in Minneapolis is one of the largest IPAs in the country. They have one of the most stringent utilization review packages I've seen. I mean, it really is tough. And they started out, they didn't have any utilization review. They could not compete with the St. Louis Parks, the group practice HMOs, and so they had to do it. And this was a medical society sponsored HMO. And over half the membership of the medical society were involved. And they brought down their rates. They're very competitive now. It's really good. And the other type of HMO, which IPA is the primary care network IPA, which we've got a couple of examples in this state. And unlike the other one, the HMO contracts only with primary care physicians, usually only primary care. And in the case of Blue Cross Blue Shield Personal Care Plan and the Health America Plan, they capitate. It is a prepaid plan for providers. It's not fee for service. Providers get a certain amount each month per enrollee. And the physician's supposed to be responsible for providing all physician services. And if they can provide it themselves, fine. If not, but they have to refer a patient, that primary care physician has to pay for that referral. And if the person needs an operation, they have to pay the physician component of that cost. They don't have any expense for in-hospital, inpatient care. I mean, the hospital portion of inpatient care. The plan does. The plan withholds a certain amount to cover hospitalizations, and they usually have reinsurance, so if anything catastrophic happens, and they always have reinsurance, that they are covered. They don't get cleaned up. but the incentives in that plan are really in the primary care doctor's hands, and they typically, in the Health America plan, they get 50% of any savings in hospital use. So if there's a reduction in hospital use, they get essentially a big chunk of money.
And that comes out from the plan and put aside $20,000 and use 50% split.
Well, it's split between the plan and the physicians.
Could you talk a little bit about moving on and walking?
Mhm.
And I hadn't heard of it.
Oh, really?
Oh, no.
Okay. You know about Health America? You ever heard of the company? It used to be called Health Plans. It's a Nashville, Tennessee-based company that Phil Bredesen runs. And Phil Bredesen used to be a bigwig at INA insurance company in the 70s, and he split off, and with some fairly big money behind him, set up at that time Health Plans, which is now Health America, and they were to their goal was to get into HMOs, and they started to pretty much buy out HMOs. They had a lot of money, and they bought out HMOs. Well, I think they have about a dozen now. And they bought out all different types. They bought out group practice HMOs. They brought out primary care network HMOs and IPAs and so forth. And one of the models that they bought was in Cleveland, and it was group. Now it's Health America Cleveland. I forgot the name, what it used to be, but it was a primary care network HMO that was started in the late 70s by a dentist named Max Davis, and it was very successful. It's now in Columbus and Akron, but they liked that model, and so they bought it, and now they're using that model as their replicating that in North Carolina. And they're last August they did feasibility work for most of 82, and late 82 and early 83, and then in the summer of 83 they announced that they were going to come to North Carolina and set up a primary care network HMO, and they targeted three cities, three metropolitan areas: Charlotte, Winston-Salem, Greensboro, and Raleigh-Durham. They also threw in Mount Olive, which I thought was cute. Their medical director is from Mount Olive. You see that list, and there's Mount Olive. But they're for profit, and they're on the stock exchange as of the end of last year. They're big. I mean, they're doing very well on the stock exchange.
What's your experience with PCNs? Does that seem to be really good?
I think it
Primary Care Network, PCN, the alphabets.
Yeah, I think it's a great model. I like it.
Could you talk a little bit about the advantages of it?
Well, the advantage of it, it's cheap to start up, and it's a lot lower cost than a group practice HMO. But on the other side is just that it tends to be much easier politically to get introduced into an area. And from the standpoint of the person doing it, that's a big, because you're using local doctors. You're not bringing in your own. I mean, HMO, Kaiser brings in their own doctors by and large, and that really makes them unpopular. But yeah, and when they come into a new area, they don't come in with open.
Well, to some extent, you're polarizing the primary care providers and
Yeah.
the specialists in hospitals. Is it that the specialists in hospitals are not as well organized as primary care providers, so that you don't get backlash? Or is it slower coming?
Well, I think in the hospitals, you know, they really don't sort of stay out. I mean, they don't want to get doctors mad at them.
Mm-hmm.
Okay, so they tend to just, you know, don't look at it as a frontal assault. And the specialists are anxious too because they start to, you know, they don't like it, but then they start to go after primary care docs that have signed on, and they
So
lose
primary
a big
care docs have enough clout that if they go for it, they can call it.
And where it's hard. I mean, it depends how the group doing the enrolling. I mean, if you're smart, you come in. You know, like Health America, we've worked some with Health. I mean, they came in and they identified the physician leaders that they wanted to work with, and that no one else knew anything about Health America. They went around and they talked to doctors, and they'd gotten their medical director on, and they have in each of the communities they have a fairly very highly visible and respected medical person involved in their operation before they did anything else. So that tends to lessen and they keep a low profile until they have a number of doctors signed, you know, really in fact signed up.
What is the main incentive for these? Is it just increased volume? You know, the lower their cost for the increased volume of patients, is that their incentive?
For the physicians?
For the physicians to give up, you know, well, is this a fee-for-service position?
No, they're capitated.
So it's prepayment.
Prepaid.
So the incentive for the physicians to join on to something like this is increased volume of patients. They'll see if they're going to a program by giving up their independent practice or whatever. Yeah.
Guarantee you. Well, there's really two at least.
Ooh, beautiful.
Yeah, we're talking about different types of models. I mean, I should have probably passed this out first. I'm sorry. Yeah. I'm not a teacher, though. You gotta remember that. I just. So we're all right. Huh?
Send it to your pop. Send it to your pop. On your hand, you know.
Let's just go down each one, make sure everyone understands the different types of organizations. You understand the fee-for-service system, right? Okay. Pretty well. Okay, preferred provider organization. We've talked a little bit about that. Most preferred providers, you know, they negotiate in the organization, and it can be arrangement too. It doesn't have to be an organization, but they're supposed to negotiate independently with each provider to establish their fees. And if you do it a whole group, then you get into problems with, you know, antitrust problems, fixing fees and so forth. So they're supposed to do it, you know, independently, and they usually involve discounts. And it's a lot of times advertised as discount fee for service. I think the ones that are set up like that are going to have problems. Theory on preferred providers, if you find efficient providers and you put them together in a plan, then you'll save money. But a lot of PPOs have turned out been more in response to competition, and they've been okay, we'll give you a 10% discount if you send your patients our way. And I think in the long run those will not be, they won't be around long. So they're mostly solo in the setting. And again, in this constraints on physician practice, there's no risk. I mean, that's where another way they differ from an IPA. There's no risk. You just.
What's to block them from doing what happened? We were studying about Medicare in Colorado, that you get a ceiling on the fees and you just start providing more services.
Well,
so that you keep
the only,
keeping track
yeah,
of income?
really not much, except if they're premium, and if the employer, has been steering patients to this preferred provider organization, realizes he's paying more than if he steered them somewhere else, he'll stop steering them. He'll change the incentives of his plan. So that's the only, I think that's the only constraint. They've got to keep costs low. And that brings up the constraints on physician practice. I think any preferred provider organization that will be successful will institute fairly substantial utilization controls. I think that'll have to be a major feature. Because they're not going to. It's like IPAs. They've found they can't just rely on the good intentions of providers. They're going to have to. If you want to put some, you have elective admission, you call us. We'll let you know. And they'll have standards. So I think it says some review by carrier. Well, I think in time it'll be substantial review by carrier. Okay, patient cost sharing is it's pretty much like fee for service with usually and the Haynes model is sort of different than any other I've heard of, but usually the patient is given an incentive. They say typically they have to pay 85% of their 85% co-payment on services. The incentive for the employee to go to a preferred provider will be that they only have to pay, the employer will pay 90%. So that'll reduce the out-of-pocket cost for the employee. And that's generally the way most of them, and that encourage employees to use them. Okay, and then no limit on where patients can go. So if they want to go to another doctor, fine. They just have to pay the higher copayment or deductible. Okay, now any question on that one?
I always have trouble with that kind of a description because you can do that with any of the others too.
What?
You can belong to an HMO and go to any provider as long as you're willing to pay him his regular.
Yeah. Some that's true. But I mean, that's not a plan design. I think they're speaking about a plan, and it is unlimited in the plan design. The HMO plan says you have to go to the HMO. If you don't, well, then you pay for it.
Yeah.
Okay, well, IPAs, I think we've pretty well covered. And there is usually the difference between IPA and a preferred provider, and is the providers are generally at risk to some extent, and there is a lock-in feature. Most plans they have to go to a participating provider. Now the exclusive provider organization, which is a variant of the preferred provider organization, and the only difference is that it has a lock-in, and it says you can only go to these providers. You can't. I mean, it's like an employer who's really done his homework or something and has identified a battery of providers that he feels are efficient, and he tells the employees that you can choose from these providers, not others. There aren't many exclusive providers. Okay, here's the primary care network. Again, the only way they differ from the IPA is there's a greater risk involved for the physician, and and it's capitation. There's capitation. It's prepayment, and it's also limited only to primary care for the capitation part. Okay, fee-for-service multi-specialty group practice. You know all that. You see the course in group practice, right? And prepaid group practice. Two types. Mr. Roth probably talked about the staff model and the group model. And staff model is something like Harvard Community Health Plan, or Reynolds. The Reynolds Plan is really a staff model. Doctors are he's sick today. And the other, in the group model, which is, I guess, the leading example, the best example is Kaiser. And their theory why they avoid staff models, they're very adamant about it. Hiring for the HMO to hire doctors or providers is just a bad idea, and that they would rather, and I guess they contract with an independent group of physicians and providers, and they usually they contract on a capitated basis. And it's a what?
Why is it different than competition?
No, it's that they don't feel. I mean, they want the medical staff, the providers, to have responsibility for the care. Okay, and they feel that it's much cleaner when they negotiate. When it's clearly their responsibility rather than a staff design where and they're adamant about it. I mean, they didn't listen any other way for an group practice issue. And then on the other side, you get people saying, "Oh, the only way is to hire them." I mean, the Reynolds people love it. The Kaiser's been very successful. And it makes their job as administrators a lot easier too. The Kaiser Foundation Health Plan doesn't have to worry. And they have to provide all the ancillary support. But then they don't have to worry, well, if Dr. Jones didn't show up today, that's not their problem. It's the group's problem, and they got to take care of it. And I think it makes sense. The providers tend to like it better, too. Don't tell anyone that, but maybe you've heard of it. Kaiser's probably coming here. I can't even break any.
Well, you keep hearing that Jim Bernstein's trying to get Kaiser to come here.
When and where?
Remember?
Well, they'll be coming to Triangle.
When?
What? I don't think. I think they're going to Atlanta, too. They'll decide Wednesday. Yeah, there's a crew care. I'm not sure. I don't know what it is. I have the list. I have the list.
A list.
As a consumer, as a customer in California, the thing was, the preventive care was not.
I know.
I mean, if you had a heart attack and you were surgery, you were fine. Wonderful care. You could be cancer.
Yeah, I had to wait forever, didn't it?
The only way I could get in to see a doctor was the person who screened the call was from the physician was to convince them I was in desperate pain for breathing. And then I could see it.
If you didn't convince him, how long would you have to?
3 times.
Yeah. Well, there's a fair bit of that. A fair bit of anecdotal evidence. I don't think they've gotten the goods on yet, but there's a great deal about it planned use in California.
Oh, yeah. I mean, my whole family did it because we ended up, I ended up a private gynecologist and a gynecologist, and we ended up just not because they were using and using that
Yeah, I have friends too, and well, I'm from California too, and they sell the same types of stories. I think one of the part of the problem I think in California is it's such a large plant. I mean, they have almost 2 million people along in Northern California, 1.5 million in Southern, so that's a third of our population. So I think something in the Triangle area would be on a obviously a lot smaller scale, but in design as well. And I don't think they wouldn't have a hospital, and they probably wouldn't have very many specialists. It'd be mostly primary care. And they probably have locations in Raleigh, Durham, Manchester. At least that's there. If anyone's really interested, I have the feasibility study that they did in the early 80s. Yeah. If anyone's really interested in that, and it's a feasibility study of a prepaid group practice establishing one in the Triangle area, and it's not so much Kaiser, but any group practice. But it's kind of it's fairly interesting if anyone wants to get into the how-tos of setting up a prepaid group.
I do hear that stuff.
So did the commission in North Carolina contact with the Kaiser consultants to come and do the feasibility study, and they said yes, wonderful?
It sounds like, but it wasn't that. Yeah, it sounds that way. But they were very lukewarm at that time in their assessment of feasibility coming. I mean, the numbers just aren't there. People and the healthcare cost is not as big a problem here. It hasn't been as it is in other areas. So they came out favorable with a lot of hedges. And in fact, for some time they were pushing us to. We get money from the Kaiser Permanente, the Kaiser Family Foundation, which is not part of Kaiser, but and they've kept pushing us to get a group practice, and they've we've never gotten any indication until recently that they were interested in doing it. So up until last year, Kaiser was not interested in expanding, and all of a sudden they see a big risk because they have such a large share of the market. They have over 4 million members nationwide, and it's a third of the total HMO membership is Kaiser, and they felt Kaiser gets too big that they're just become too vulnerable, and they want more HMOs and more different types of HMOs. So
Maybe think too big deal to eliminate competition.
yeah, there'll be that, and then they could become a target. The more out there, the better. But then last year they changed their thinking a little bit and decided that they really haven't had much of an impact in the East. I mean, then they came into Georgetown, and they came in with Kaiser Georgetown Health Plan, and that was primarily to Georgetown. The Georgetown Health Plan was going under, and it was a rescue operation. They didn't want a prepaid plan to go under in Washington D.C. That would just politically would be a real problem. So they came in and took it over, and it's doing very well. But in fact, I talked to someone last Friday in Boston that said that anyone could have come in and turned that one around. It was a great plan. It just needed some good management. But then they went to Hartford after that, and it was also more of a rescue operation. And then in last summer they decided they were going to expand to at least one or two other places, and they were trying to go to the Southeast. And they looked at us, and looked at Atlanta, and looked at Nashville and Orlando. No.
doing it for years, so they really gonna do
Yeah, their board meets this Wednesday, and they'll decide. They'll make their decision then, and then there should be a press conference within a week or two.
Also, the rumors about someone coming in and building it.
When you find out, let me know. Okay. I don't know about that.
This is strictly my own interest. Did they ever talk about different matters as physicians and seniors? Are they mentioned, or are we just part of the
Mention in what way?
just encouraged, is what I want to do.
Yeah. Well, certainly, I think that it, as part of alternative plans, FMPs and PAs generally play a pretty big role. There's certainly Kaiser and other ones I've looked at. That's one reason I like the primary care network model. It gets care back to the level, the point where I think it should be, and not. Right now, you can go in. I did this a few weeks ago, but I can pick up a phone and go to see any doctor I want. And there's so much of that going on. And 10 years ago, you couldn't do that. Today, it's right. My background is rural health and Office of Rural Health Services. I also work for that organization. And our major program for the last 10 years was, using nurse practitioners and PAs in our rural centers. So I'm a big believer. I think with all the new delivery models coming around, I think will be good for nurse practitioners. You in the master's program? I guess that's the only one they have now.
Here.
Here. Where do you want to go after? What types of? How's the market today?
I want to go to Europe. I don't know.
Actually, the most urban area is Haynes, but
Oh, really?
in that sense, we're all over parts. The islands are understood.
And you've been up there? That's where you're from? That sounds good. Where are you gonna?
Probably the Northeast, or possibly this area. I'm not quite sure yet. It's pretty easy getting to get a job up around the Boston area. So you can use a nurse practitioner and physician assistant role, so quite a bit up there. I'd like to go up there, but I'm not really sure.
You were serious? What time is it?
2:30.
2:30. Really?